Our next presenter is Dr. Mathew James. Dr. Mathew is a consultant ophthalmologist at Medical Trust Hospital. He did his post-graduation from All India Institute and has done had a lot of publications. He has a definite advantage over a lot of us neuro-ophthalmologists and ophthalmologists. He is married to a neurologist, Dr. Sangeeta. Over to Dr. Mathew.
Thank you, sir, for the introduction. I thank KSOS for giving me this opportunity. I'll be speaking to you on occipital lobe lesions. Occipital lobe lesions have always mesmerized me with the different presentations, the symptoms that it can actually show. So I'll be presenting 4 cases which shows different kinds of symptoms. The first one is a 72-year-old male who presented with headache in the occipital region and a decreased vision on the right side since 2 weeks. But he had a history of difficulty to approach and grasp objects on his right side since few months. On examination, his vision, he was able to identify the movement of fingers at 6 meter distance, but was unable to read anything on the Snellen's chart. Otherwise, his eyes were perfectly normal. Visual fields was done, and he was found to have a right homonymous hemianopia. Imaging was straight away done because anyway hemianopia is there. So we found a large occipital lesion which was involving the left occipital cortex, extending to the parietal, temporal, and into the splenium basically. So the highlight that I would like to give is what was the reason for the symptoms. The diagnosis was basically a high-grade glioma. Now what was the reason for the symptom? As I told you, he was not able to read anything on the Snellen's chart. So he had basically a difficulty in reading, that is alexia. Now why do such patients show the symptoms? Just because after an image is actually processed in the occipital lobe, the information has to be given to the language area. As you know, the language area is on the dominant hemisphere, that is on the left side. So the left cortex is definitely damaged, so that connections are definitely lost. But usually in a patient, it has an intact other lobe, that is the right occipital cortex, which can actually pass on the information. Now in this patient, the difference was that the lesion was extending to the splenium basically. So those connections were also lost in this patient, and as a result, actually the patient was not able to read anything on the Snellen's chart. So that was the reason for the alexia that he was showing. So preferably in such patients, actually if you like to look for a visual acuity, you should use preferential acuity charts like Teller's acuity chart and all those things. Only those can give actually what is the actual visual acuity of the patient. Now the patient also had difficulty in grasping the objects on the right hemifield, and that was because like even if the patient is not having a visual field defect, even then if the connections from the visual association area to the motor cortex are affected, the patients can have difficulty in grasping the objects in that hemifield. So this patient was having that difficulty since few months prior to, even before he noticed that he has developed a visual field defect. So these are the 2 symptoms that I would like to highlight in this case. Now the second case is a patient who presented with headache and acute onset colored halos. Here I would like to highlight on the symptom of colored halos. Many a times we sometimes ignore this complaint when the patient says this, or sometimes we say that it is just a migraine. Otherwise his eyes were perfectly normal. Just we went for a visual field examination and we found he had a left homonymous hemianopia. Imaging was done and we found that he had an occipital cavernoma in the right side, and also had epileptiform discharges. So the reason here was like the colored halos was due to actually an occipital seizure which was ongoing in that patient since last 1 week. If we had missed it, we would have missed the diagnosis and it would have become severe. So as an ophthalmologist, patients, when the patient comes with colored halos, actually we should give importance to those symptoms. So how do you distinguish between whether it is a seizure or a migraine? If it occurs in the same manner every time, right, it will be stereotypic. Or else if it occurs very rapidly within seconds, or else if it is just confined to a hemifield, then always think that there is a possibility of seizure and go ahead with the further investigations. Now the third case is a 77-year-old male who presented with giddiness and decreased vision in both eyes, sudden onset. He already had a history of right hemifield loss due to a left hemifield loss due to a right occipital infarct 1 year back. He was on treatment. Suddenly he developed the other side stroke also. That means he developed a bilateral occipital stroke. You can see in this image, one is an old stroke and one is a fresh stroke basically. So he had a bilateral occipital. So in fact we know that he will have a macula spared area. So he will have a tunnel vision through which he should be able to read. But this patient, I tried to do everything, but he was not able to read anything through that field. And in fact, finally I concluded that he was having a visual agnosia basically. What happened is that in such patients actually, the patient cannot actually have the logic to identify what is the thing. So you give a line diagram or you give a pencil or a stethoscope. He will say that this is a rope, there is something attached on the end, but he cannot say that it's a stethoscope. Or he cannot say that it is a pencil. But if you give the thing into his hands, suddenly he will say, this is a pencil, this is used to write. So when he gets a tactile stimulus, he's able to identify, but otherwise visually he cannot identify. So in such patients actually, we should also think that there are other things other than just measuring the visual acuity. So this was agnosia. Now I would like to end my presentation with one talk that you know the story of redox syndrome basically. George Redox was actually a neurologist, and he found that after World War I, when they used to have helmets, small helmets actually. So the soldiers used to have injuries in the occipital lobe, but these soldiers were actually able to see even through the blind field. So that is how the redox syndrome diagnosis came, and later on the pathways were actually diagnosed. So the question is, we as ophthalmologists might be able to diagnose new symptoms, new pathways, or name it under us. You might, some things which during the development of this presentation, I came to know about palinopsia. It is something like patient is seeing something which even after the target has gone. The patient says that താക്കോൽ അവിടെ ഉണ്ടായിരുന്നു, പക്ഷേ പിന്നെ താക്കോൽ ആരും എടുത്തോണ്ട് പക്ഷെ എന്നാലും താക്കോൽ അവിടെ തന്നെ ഇരിക്കുന്ന പോലെ എനിക്ക് തോന്നിക്കൊണ്ടിരിക്കുന്നു. Such things can happen. So these symptoms also can be considered as a lesion of occipital cortex. The prosopagnosia, as you know, then even patients can have actually micropsia, metamorphopsia due to the cerebral causes actually. We know about retina, macular edema causing micropsia, but even cerebral causes can also cause micropsia and metamorphopsia. And lastly, it can also cause color blindness. That's all. Thank you very much for.
Thank you, Dr. Mathew, for that wonderful presentation.